Okay, so today I will tell you about heart failure. So, heart failure or cardiac failure, what is the definition? So, basically, the definition is that heart failure is a state in which the ventricles at normal filling pressure or in adequate intravascular volume cannot maintain an adequate cardiac output to meet the metabolic needs of peripheral tissue or can do so only with elevated filling pressure. Now, this इसको सुन के everyone will be like, what is this definition? I don't understand anything. Okay, so first, in easy way, I will tell you. Now, if I want to show you a heart, I will just put it as a box with 4 chambers, this being my right atrium, right ventricle, left atrium, left ventricle, and this is my aorta, and this is my pulmonary vessels. Okay, now what happens is that कि अभी ये जो ventricles है, these ventricles, be it your left ventricle or your right ventricle, the heart is failing or not will depend upon this ventricle. Like the cardiac output depends on the ventricle only. How much? So the left ventricle is giving to the aorta, and aorta will give blood to all the peripheral tissues, right? So abhi it's saying that heart failure is a state in which even if the left ventricle is getting, like left atrium is giving blood to left ventricle, and left ventricle is in an adequate pressure, and the volume which the left ventricle is receiving is also fine, so everything is adequate. So there is an adequate intravascular volume, and there is also a normal filling pressure. Okay, there is also a normal filling pressure. Even after, despite all this is present, okay, all this is present, the heart is not able to pump blood to meet the demand of the body. Okay, so or it is able to meet the demand in an elevated filling pressure. Okay, or it is able to meet the demands in an increased pressure. ओके तो नॉर्मल प्रेशर में वो काम नहीं कर पा रहा है, बट जब वी आर इंक्रीजिंग द प्रेशर तब इट इज एबल टू मीट द डिमांड ऑफ द बॉडी. ओके, सो दिस इज व्हाट इज हार्ट फेलियर बेसिकली, राइट? नाउ this is what, so now I'll just read out the definition again and you will understand. So heart failure or cardiac failure is defined as a state in which the ventricles at normal filling pressure and at adequate intravascular volume is able to meet the metabolic needs, is not able to meet the metabolic needs, my apologies, is not able to meet the metabolic needs, or it is able to meet the demands in an increased pressure. Okay, this is the definition. Now, why is this happening? It can result from results from either a structural deformity or a functional deformity. Okay, it is either because of a structural deformity या तो functional deformity. What do you mean by that? या तो there is some kind of structural deformity in the ventricles, that is why it is not able to meet the demand of the body, or there is some kind of functional, like the left ventricle is structurally fine but it's not able to function properly, and that's why it is not able to meet the demand of the body. Okay, now we will see about the pathophysiology. So to understand the pathophysiology, we have to know two terms. There is one term as preload, one is your afterload. Okay, so as I told, we have to know about two terms, preload and afterload. So सबसे पहले, what is preload? Preload, if you have to understand in a very simple language, is that कि the amount of blood, okay, wait, amount of blood the ventricles receive. Okay, the amount of blood the ventricles receive. And what is afterload? The amount of pressure the ventricles exert against the systemic vascular resistance. तो इसका क्या मतलब हुआ? अभी जैसे प्रीलोड में यू आर गेटिंग, द लेफ्ट वेंट्रिकल इज गेटिंग सम अमाउंट ऑफ ब्लड इन फ्रॉम द लेफ्ट एट्रियम, राइट? So for example, left atrium is giving to your left ventricle, and that is the preload. Like it is basically the diastolic capacity. You can also say it is the diastolic capacity. So how much is the left ventricle taking, like how much it's relaxing, how much the left ventricular muscles are relaxing in order to get blood from the left atrium. So it basically says about the contract, like it says about the compliance of the left ventricle, okay, of the left ventricle. Whereas now when afterload is basically jab left ventricles now get blood, now it has gotten blood, now it has to do systole, it has to contract. Now obviously in order for the blood to pass from left ventricle to the aorta, the pressure which left ventricle has to exert should be more than the aortic pressure, है ना? So that pressure which it has to exert against the pressure of the aorta or the systemic vascular resistance is called your afterload. So in other words, you can say the systolic capacity. Okay, so this much I hope you have understood. So these are the two terms which you have to know about, preterm and afterload. Now coming to pathophysiology. So the main problem in your heart failure, okay, is your cardiac output is decreased. Okay, so your cardiac output decreased. जब cardiac output decrease होने लगता है, that is because it is the main problem of heart failure. So one of the main problem for heart failure is cardiac output. Now how does body react when there is decreased cardiac output? So first of all, when the body detects decreased cardiac output, it will go for some compensatory mechanism. ठीक है? So it will go for some compensatory mechanism. Now what is that compensatory mechanism? So first of all, remember there are two things happening. One is your sympathetic activity, and the other one is activation of your RAS pathway. Okay, the body is trying to compensate. So because the cardiac output, the body has detected that my cardiac output is less, so I have to do something in order to increase the cardiac output because I don't want further damage to occur. So this is the sympathetic activity, and RAS pathway gets activated. So sympathetic activity mein kya hota hai? There will be vasoconstriction. Now obviously when there is vasoconstriction, it is the body is trying to adapt. The body is trying to help to overcome the decreased cardiac output. So vasoconstriction will occur, and it will also increase the systemic vascular resistance. Okay, systemic vascular resistance will increase. Okay, and because of systemic vascular resistance, when it increases, what will happen? The left ventricular pressure will also increase. Okay, because abhi the afterload will increase basically. Do you understand? So afterload is increasing. So do you understand the concept? So sympathetic activity में क्या हो रहा है? The main aim is कि हम लोग को we have to increase the systemic vascular resistance so that LV pressure becomes more, and वो pressure exert more pressure exert करके it is somehow maintaining the cardiac output. Okay, and RAS pathway, what will it do? Everyone knows that, right? So what happens is that this is a renin pathway. So there'll be sodium and water retention will occur. Okay. And also, so what happens when sodium and water retention occurs? There will be more volume, circulating volume in the body, and that is why LV will get now more blood, right? So it will get more blood. So what happens? Preload is increasing. Preload increased. So the body is trying to compensate by increasing the afterload and increasing the preload. These are the compensatory mechanism. So at one point when the body is doing this compensatory mechanism, it is fine, all and good. But at one point when this occurs too much, this is an excess, okay, the body, it will go in adverse effect. Now because of this increased afterload and increased preload, there is an adverse effect which is happening, and that is why it will lead to most of the manifestations of heart failure, because it becomes counterproductive and accounts for most of the manifestations of heart failure. Right, something else. Now there is something called as types of heart failure. Okay, so the types of heart failure, first being acute and chronic. Okay, so acute meaning that it is a sudden onset. Obviously, sudden onset of a new heart failure or worsening signs and symptoms, right? And then acute meaning like it is going to be gradual. Okay, it is gradually developing. And what happens here, one of the main differences which I will tell is that, okay, first of all, in acute there will be no peripheral edema, because edema develops slowly only, right? Edema will take time to develop. So in acute attack, whenever there's an acute case of heart failure, there will be systemic hypotension, okay, systemic hypotension, but there will be no peripheral edema. Okay, now one more thing, if you see here, gradually developing. So what happens is that the systemic arterial pressure is well maintained. Pressure is well maintained, but there will be signs of peripheral edema. Okay, so but there's something, there's more types of classification also. One is your heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Okay, so if heart failure with left ventricular ejection fraction more than 50%, okay, it is your preserved ejection fraction, but reduced meaning it is less than your 40%. Okay, and if it is in the middle range, it is called your heart failure, like it is between your 40 and 50%, you will say it is your heart failure with mid-range ejection fraction. Okay, so heart failure with mid-range ejection fraction, right? This is what you have to understand. Next being your low output and your high output. So as I told you about the pathophysiology, I was telling you here that the main problem is decreased cardiac output. So you might say, then is there a heart failure when there is increased cardiac output? I'll be like, yes, it's not that common, but yes, high output failure can occur in cases of, like, that occurs when the cardiac output is increased. It is correct, the cardiac output is either more or normal, but the body's demand is too much that even an increased cardiac output is not able to meet it. So that I will say in case of thyrotoxicosis, okay, and anemia, it is more, because the body's demand is only more, but even body's demand is so much more that increased cardiac output is also not able to meet the demand. Okay, and low cardiac output is basically what we discussed only, right? Example, low output can be because of your valvular heart disease or your ischemic heart disease, pericardial disease, and because of that there is a low cardiac output, right? Okay, next is your left-sided and right-sided heart failure. Next is your left-sided and right-sided heart failure. So what is your left-sided and right-sided heart failure? So whenever there is a pathology involving the left side of the heart, which includes the left atrium, left ventricle, and the mitral valve, it is mostly your left-sided heart failure. Whereas in the right-sided heart failure, you will have your tricuspid valve, right artery, right atrium, and right ventricular getting affected. In the right ventricular, like right heart failure, you will see more signs of ascites, fluid accumulation, peripheral edema. You will have raised JVP and stuff. But in left-sided heart failure, you will see pulmonary symptoms, which will be pulmonary hypertension, pulmonary edema, pulmonary congestion, right? So all this. Pulmonary hypertension, if you see, it's more of a chronic one. Chronic left-sided heart failure can lead to your pulmonary hypertension, and in acute, you will have mostly your pulmonary edema as such. Okay. Now, you also have your something called as forward and backward. Okay, now for example, in the heart, basically what is happening, this is the heart. I'll take your left ventricle in consideration. Okay, now what happens is that either the blood from the left ventricle is not able to move forward, or the blood from the left ventricle is going backward. Okay, this is called your backward, and this is called your forward. So when is it not able to move forward? Can you tell me? When is it not able to move forward? You can say it is aortic stenosis. Okay, maybe some kind of aortic stenosis is not letting this thing move. And if there is a backflow, maybe you can say there is a MR, right? So that also you can understand. This is also one of the cause of heart failure. Right, okay, this was the causes of the heart failure. So as you can see, the common causes of your heart failure. So heart failure, as I told you, can be because of a pressure overload, or can be because of volume overload. If you remember at least this part, it was enough, I guess. So pressure overload, first of all, when there's a pressure overload, when there's a systemic hypertension or there is a pulmonary hypertension, and there's aortic stenosis and pulmonary stenosis, so that's a pressure overload, right? Volume overload, obviously we know mitral regurgitation, as I told you, aortic regurgitation, ventricular septal defect, patelis ductus arteriosus, atrial septal defect, and all that. Okay, inflow obstruction of the ventricle. So inflow is not occurring. Why? Because of mitral stenosis, tricuspid stenosis, or endomyocardial fibrosis. Impaired ventricular function is not happening. Ventricles is not able to function properly because of cardiomyopathies or myocarditis, or myocardial infarction also can be a role. Now, what is the precipitating factors? Now, precipitating factors can be because of anemia also. I told you anemia because the body's demand is more, so it's not able to meet that. And then pregnancy also same reason, thyrotoxicosis also same reason. Infections can be the cause, and any kind of cardiac arrhythmias also is there. So when there's arrhythmias, the ventricles and the atriums are not even coordinating, right? That can also lead to heart failure. And supervening heart disease like myocarditis, infective endocarditis, myocardial infarction, then systemic hypertension, as I told you, pulmonary embolisms, drugs like beta blocker, corticosteroids, NSAIDs, and increase salt intake, because that will lead to water also will be more in the body, and that's why there is more volume in the body, right? And that will also lead to increased preload, and which will also predispose to heart failure. Physical and emotional stress, poor compliance with therapy, right? Okay, now we are going to talk about clinical features. So as I told you, always have to divide into signs and symptoms. So in right-sided heart failure and left-sided heart failure, we're going to talk about separately, even though you know a kind of gist right now, but I'll just tell you properly. So right-sided heart failure has more of signs, and left-sided heart failure has more of symptoms. This you have to remember, guys. Okay, so we are going to start with left-sided heart failure, which has more of symptoms. So obviously whenever there's left-sided heart failure, it will even affect the left atrium. It will also affect the pulmonary circulation, right? So because the lungs are involved, you will have dyspnea, which will be initially on exertion, but but over time it will be even there in rest also. There will be orthopnea, PND, okay, and acute pulmonary edema can occur. And because of acute pulmonary edema, whenever there is a pulmonary edema occurring, you can have a severe breathlessness and then cough with copious pinkish frothy sputum and bilateral crepitations. Okay, so all this is due to your pulmonary congestion. So whenever there's a pulmonary congestion, you will have all this symptoms. Now what happens is that due to decreased cardiac output, okay, what will happen is that there's decreased urine output, oliguria, fatigue, weakness, confusion in severe cases, because your cardiac output is less. So obviously your urine output will also become less, right? Right, okay. Now, and then what will be your signs? So there'll be enlargement of left ventricular, because the pressure which the left ventricle is exerting is so much that it will lead to your enlargement of left ventricles, okay? And gallop rhythm S3 you will hear, crepitations as you will hear because there is a pulmonary edema, pleural effusion, displaced apex beat, okay, plus murmur you will hear, tachycardia and tachypnea you will have, okay. Now what happens when there's a right-sided heart failure? There'll be more symptoms of systemic venous congestion. So because of that, there'll be leg swelling, and there will be also pain in the right hypochondrium, ascites, okay, which will be also due to systemic venous congestion. You have also symptoms of oliguria, because again there is decreased cardiac output. And then you have something called as cardiac cachexia also, which is severe anorexia, weight loss, and malnutrition. And there'll be dyspnea when even the left-sided heart failure also follows. Signs will be there's increased JVP, there is hepatojugular reflex will be positive, hepatomegaly, edema, and pleural effusion and ascites also will be there. Okay, now there is something called as Framingham criteria for heart failure. So you have to, it is used for diagnosis of heart failure. So you have a major criteria and you have minor criteria. So major criteria being PND, neck vein distension, crackles, cardiomegaly, acute pulmonary edema, S3 gallop, increased ventricular pressure, increased venous pressure, and positive hepatojugular reflux. So there are 8 points in major and 7 points in minor. Okay, so you have major you have PND, neck vein distension, crackles, cardiomegaly, you have acute pulmonary edema, S3 gallop, increased venous pressure, and also hepatojugular reflex. Minor, you have your extremity edema, nocturnal cough, dyspnea on exertion, hepatomegaly, pleural effusion, tachycardia, vital capacity increased by 1/3 from normal. So for diagnosis, there is one major and two minor criteria. That is how you'll diagnose heart failure. Okay. Now, what happens to the investigation? So investigations, you will do a chest x-ray. So there's a prominence of upper lobe vein. Upper lobe vein is prominent. So the prominent upper lobe vein, you have a curly B lines which is engorged peripheral lymphatic seen in the lower lobe. So this is the upper lobe vein is prominent, and in the lower lobe you will see a lymphatic enlarged peripheral lymphatic, which is called your curly B lines, and you have phantom tumor fluid in the horizontal or oblique fissure of the lobe. You have bat swing, increased bronchovascular marking in the perihilar areas, pleural effusion and cardiomegaly. So as you see in the chest x-ray, this is the prominence of the upper lobe, right? In the lower lobe, you have the curly B lines, which is basically the prominence of lymphatics. You have pleural effusion will be there. You have bat wings appearance, which is pulmonary vasculature is increased. You have cardiomegaly, and you have also pleural effusion. As you can see, the pleural effusion is here. Can you see? Okay, so these are the 1, 2, 3, 4, 5 points you have to remember. Prominent upper veins, curly B lines, you have a pleural effusion, cardiomegaly, bat wings appearance. Then in ECG, as you know, there can be presence of hypertrophy, right? If there is a left ventricular hypertrophy, you will have a left-sided deviation. If there's a right ventricular hypertrophy, you will have a right axis deviation. Okay. Now, there's another test called BNP. So, serum BNP and NT-proBNP is increased in heart failure. It's a highly sensitive test and it is used as mortality predictor also. So, echo if you do, you will see that there's a valve. So, you will see assessment of valvular function, chamber size and shape you will see, and you will see systolic and diastolic heart failure and all that, right? You'll also do your thyroid function test, you'll do RFT and LFT also. Okay. There's something called as stages of heart failure also, because you will manage based on the stages of heart failure only. So stage A, okay, this is very complicated. I'll just tell you in very simple way. So if you see about stage A, is basically that patients will have the risk factor, that is they have hypertension, they have diabetes mellitus, they have hyperlipidemia, okay, they have coronary artery disease, they have thyroid disorder, alcohol use, but they do not have any structural or functional heart disease and are asymptomatic. Okay, that is what is stage A. Stage B is basically your patients who have already developed structural heart disease such as myocardial infarction, left ventricular dysfunction or left ventricular hypertrophy, but are asymptomatic. Stage C is basically your patients will have structural heart disease with prior or current symptoms of heart failure. So they have structural heart disease and they have prior or current symptoms of heart failure. Stage D is with advanced end stage refractory heart failure and remain persistently symptomatic despite maximum pharmacological and device therapy. So now we will just see here once also. Stage A basically means that patients are at risk, but they are at risk because they have all the risk factors like hypertension, hyperlipidemia, CAD, diabetes mellitus and all that, but they don't have any structural damage in the heart, and they're asymptomatic. Okay. Stage B is pre-heart failure. So they are having a disease, like they have basically myocardial infarction they've had, and they have left ventricular dysfunction and left ventricular hypertrophy, but they're still asymptomatic. Stage 3 is basically they have the structural abnormality and they have signs and symptoms. Stage D is advanced heart failure, where they interfere with the daily life, and even despite GDMT, which is guideline directed medical therapy, so even after pharmacological and device therapies, they are not able to maintain a good, they are still having like very severe symptoms of heart failure. Okay. Now, when I talk about management of chronic heart failure, first of all, the main aim is that I have to reduce the preload, reduce the afterload, and have to increase the contractility, right? So you have to give physical and emotional rest. Produce absolute bed rest is rarely required, but correction of obesity you have to correct. Salt restricted diet you have to give. Okay, avoidance of salt retaining medicine like NSAIDs you should not give. Alcohol elimination, smoking cessation, exercises, and then you will come with drug therapy. Drug therapy mostly is diuretic. So diuretic, what will happen is that it will it will promote the sodium and water excretion. So when sodium water excretion occurs, preload will decrease, and that's why the heart will, so there's decreased tension also, and cardiac efficiency will increase. Then what are the drug which you'll give? Furosemide you are giving, okay, 20 to 40 mg OD or BD. But edema can still persist. Even though you're removing sodium and water, edema can still persist despite oral loop diuretics. So in such cases, you have to go for IV furosemide, which is 5 to 10 milligram per hour, plus thiazide diuretics. Then you have to give AC and ARB inhibitors, and you have to give angiotensin. There's one more drug which is called your angiotensin receptor neprilysin inhibitor, sacubitril and valsartan. So if you see this diagram, sacubitril will inhibit the neutral endopeptidase, leading to increasing the natriuretic peptide, and bradykinin, which will lead into valsartan. Okay, sorry, vasodilatation. Okay. Now here, this is from Davidson only. So AC inhibitors, ARBs, and beta blockers. So what drugs are we using, and how much is the starting dose, how much the target dose? You can learn it with this. Okay. And yes, so beta 2 receptor antagonist. So all this, if you remember just this diagram, which is from Davidson, which is a very good diagram, you will understand everything, and you will understand the mechanism of how each and every drug acts. So beta blocker, if you see, it is inhibiting the enhanced sympathetic activity. Okay, diuretics is reducing the salt water retention. Okay, an AC inhibitor is basically inhibiting the ACE enzyme, and that is not leading to your angiotensin 2. ARBs is not leading to, will not let your angiotensin 2 to bind to the angiotensin receptor, and that will decrease the vasoconstriction and sympathetic activity also. Okay, this is what is the thing. And then non-pharmacological therapy also is there, which is your implantable cardiac defibrillator. You have cardiac resynchronization therapy also is there. Okay, you have cardiac coronary revascularization and cardiac transplantation also exist. So these are your non-pharmacological treatments. Okay, so coronary revascularization and all that, and ventricular assisted devices. So the best one is cardiac transplantation, because it's better, because but if someone whose lungs has also been damaged, which is, yeah, if someone's lungs has also been damaged, you have to go for a heart and lungs transplant, because if you do for heart also, the heart will eventually become bad because of the lungs, right? Okay, that is what is my thing here. Acute heart failure, there is a classification of acute heart failure also, which is which is nothing but which is based on your hypoperfusion and so evidence of hypoperfusion and evidence of pulmonary congestion. Okay, so you have to talk about evidence of hypoperfusion, okay, and evidence of pulmonary congestion, right? So evidence of hypoperfusion means that you will have cold extremities, you have narrow pulse pressure, you have impaired mental status. All this means that there is evidence of hypoperfusion. Whereas when there is evidence of pulmonary congestion, it means that there is PND, orthopnea, okay, dyspnea, you have your peripheral edema, okay, peripheral edema, crepitations. So all that means that you have evidence of pulmonary congestion. Evidence of hypoperfusion means you have cold extremities, you have your hypotension, you have your narrow pulse pressure. Okay, so these are the evidence you have to check for. Now, how will you classify? Now, if I have to classify, I'll write hypoperfusion. So, on the basis of hypoperfusion and on the basis of pulmonary congestion only, I'm going to classify. So, you have something called as hypoperfusion. You have something called as hypoperfusion, which is absent, and hypoperfusion, which is present. Okay, and the next one will be your pulmonary congestion. Absent, pulmonary congestion, present. Pulmonary congestion is absent, you will write, because there is no hypoperfusion. So will the extremity be cold? No, it won't be cold. It will be warm. And when there is there's no pulmonary congestion, so pulmonary edema hoga. There will be no pulmonary edema. So that's why it's dry. Now similarly, tell me, if there is hypoperfusion is present and congestion is absent, what will I say? Cold and dry. Okay, what about this one? Hypoperfusion is not there, but pulmonary congestion is there. So hypoperfusion is not there, so warm. And pulmonary congestion is there, so wet. What about this one? Hypoperfusion is there and pulmonary congestion is there. So it means that it is your cold and wet. So can you tell me which one has the better prognosis, which one has a worse prognosis? Obviously, this one is having a better prognosis and this one is having the worst prognosis. How will you treat now? Okay, now treatment is that, now treatment is very simple. Whenever there is like warm and dry, okay, warm and dry, there is no treatment required. Okay, there'll be nothing. But if you have cold and dry, dry is okay, but cold, right? So you have to give your inotropes. You have to give your inotropes for cold. Now this is warm and wet. So for warm, it's good. Warm, you don't have therapy, but wet, you have to give diuresis. Now this one, you give both inotropes and diuresis. Is that understood? Okay. Before that, before doing all this treatment, I will first resuscitate the patient. I will resuscitate the patient. I'll give them therapy and ventilatory support if needed. I will correct the predisposing factor. Okay, all of that. And then I will use this treatment. I will use this one. So, inotropes and diuretics. You have to just understand which one and where you are using. That's all.